Yeah, the final talk today will be by Sylvia Escher. She is chemist by education. Her PhD was on structure-activity relationship of chemicals. Since 2016, she is at the Fraunhofer Institute for Toxicology and Experimental Medicine in Hanover, and where she leads the department the department in silico toxicology. She has coordinated several projects in national and international initiatives, and she is currently, for example, involved in the Risk Hunter initiative, where she leads the work package on toxicokinetics. The floor is yours.
Thank you. Okay, thank you for this nice opportunity today to speak about PBPK modeling and how we use this in next generation risk assessment. And actually, I'm at ETEM since 2006, but I don't mind. Okay, next slide, please. I have to do this on my own, sorry. Yeah. So. Yeah, okay, I think I wanted to start with something that simplifies next generation risk assessment quite a bit. So here you see on the left-hand side how we would like to do hazard identification next generation risk assessment, and you have seen that the battery that Alan, so to say, has proposed could have been used to do this for one endpoint like DNT, or what Bob has presented this morning when we use toxicogenomics to parameterize this hazard identification. And then we will, so to say, factor in all these different new approach methods like in vitro, in silico, and other models into, for example, AOPs and AOP networks to come to a kind of hazard characterization. And then after we have identified the hazard, we also would probably like to know what is then the corresponding human threshold. So what is, so to say, what we have now in this hazard identification is kind of an EC20 or an AC50, what Nicole has shown. And then we want to translate this to the human situation. And here we can use PBPK modeling, physiological-based kinetic modeling. And you see this here on the right-hand side, where we see an exemplary picture. So here we want to develop models that can estimate the human equivalent dose based on an EC20 value, for example. And we want to parameterize these models as much as possible with also in vitro ATME data. So we want to step away from in vivo animal data and, so to say, make a full generic in vivo PBPK model. So here is a kind of overview what a PBPK model, how a PBPK model looks like. So it is, so to say, a multi-compartment model. It breaks down, so to say, the physiology of a human organism into different compartments. And we use it to simulate the absorption, distribution, metabolism, and elimination in tissues. And this is mainly based on ordinary equations. I think most of you will know this already, very basic stuff. But what do we need to, so to say, bring this into practice? We need basically three different types of parameters. We need, on the one hand, the physiological parameters that describe the organism, for example, blood flow, volume of the tissues, and how everything is connected. Then, in addition, we need compound-specific data that characterize the ATME properties of these compounds. And for the next-generation risk assessment, here we want to use in vitro ATME data mainly. And then, if you want to do some kind of external to internal exposure estimate, we also need exposure data. So today, I will introduce to you mainly the bottom-up approaches, where we build a generic model built on, based on these physiological parameters, and then we use the in vitro ATME data to characterize the properties of the specific compound, and then use this for in vitro to in vivo extrapolation, for example. So this is, so to say, how we will use it in principle. On the left-hand side, you see that we have, so to say, identified in one of those assays a kind of dose-response relationship in vitro. Then we correct for the effective in vitro concentration, and then we extrapolate the derived EC20 value, for example, to the corresponding in vivo value, for example, corresponding value in plasma or in tissue. And then we can even go one step ahead by reverse dosimetry and then extrapolate to the external concentration that should have caused this human equivalent dose. And this plasma or tissue concentration, or even the external concentration, would then be the point of departure for risk assessment. So this is, so to say, kind of the backbone. And now we look, so to say, into some examples where we already used this concept to come up with a human equivalent dose for risk assessment based on purely NAM-based assessments. And here I like to mention one of the case studies from the recent EOToxos project. And luckily, already Bob introduced this case study when he talked about VPA, and we will have a closer look into this again with regard to the kinetic modeling now. So the read-across case studies is one of the success stories of EOToxos, and we will now see how we used PBPK modeling in read-across to assess a whole group of compounds. So we asked ourselves for these 11 or 13 compounds that you see here on the top, how can we characterize their hazard by using NAMs, and we used an AOP to inform our testing strategy. We will not, so to say, speak about this today because we are now especially interested in the kinetic aspect. But you can see here that we used a variety of different NAMs to characterize the hazard, and the hazard hypothesis was some of them induce liver steatosis, others do not. And then each of these assays that you see here down on this slide, they derive then some kind of benchmark concentration, so kind of an EC20 value for these different assays. And now we want to learn, so to say, how to translate this to a human threshold, because an EC20 per se does not really tell us anything about the human threshold. The first step, and this was mainly done by Satara, was to step away from the nominal concentration, the thing that we dosed into our in vitro assays, to come up to the effective intracellular and free concentration in the in vitro assay. So we applied some in vitro biokinetic modeling, and here we applied the model that has been developed by Kieran Fisher and colleagues, which is called the VIVID model. And in this specific case study, the main problem was not plastic binding or binding to something else or proteins. The main problem was that these VPA analogs, they are all carboxylic acid. They, so to say, decrease the pH value in the in vitro system, and this has an impact on their uptake via the cellular system. So we had to adapt for that, and we adapted that with an experimental approach. So then we keep the pH stable, and then we could, so to say, calculate the free unbound intracellular concentration. Then we take this free unbound concentration, and then we apply the PBPK model to estimate the human threshold. You can see this on the right-hand side. And what you can see here is the Satara model, and you can also see that we basically used two experimental or NAM data for that. We measured for all compounds, or we predicted the plasma protein binding, and we measured the intrinsic hepatic clearance. Okay, how does this look like, the whole process? So for one compound, VPA, we had the luxury that we had an in vivo ATME study with humans, and we could, so to say, build the PBPK model based on the study. This is shown here on the left-hand upper part. And you can see here the simulation compared to the measured data. These are the red boxes, works fairly well. So the simulation for VPA in the PBPK model, so once it's uptaken, works very well. So we could prove that the uncertainty in the model is very small, so it works well for one analog out of 13. And then we measured or predicted. First, we predicted the plasma protein binding for the remaining 12 other compounds, and you can see that the protein binding increases with decreasing side chain length. This is shown on the right-hand side. Yeah, and we also then measured in vitro the hepatic clearance, so how quickly are those compounds cleared by primary human hepatocytes. And then we used this one model that has been validated and approved, so to say, by one compound to simulate all the other compounds, and this is shown down left down here. And you can see there that here we compare it to the data that we got from a rodent study, and you can see that the predicted value based on the NAM endpoint is, so to say, fairly similar to what we get from our NAM-based approaches. And probably the question is, which type of NAM data did we use? We used the key event which was closest to the ethical endpoint, so the lipid accumulation in a liver model. Okay, so we have also, so I'm working at Fraunhofer ITEM, and here we have a special focus on inhalation toxicology, and I like to show you also some recent advances in inhalation models. So for inhalation, the situation is a little bit more heterogeneous, because here we not only have compounds that are soluble and can be applied submerged, but we have different types of inhalable compounds. We can distinguish gases and vapors and particles, either lipid particles or solid particles. And here you can see the basic processes that we would like to address in such a PBPK model. So based on deposition for particles, we will have then, for some of them, dissolution, but we will also have phagocytosis by macrophages and clearance by macrophages, or mucociliary clearance by the respiratory tract. For gases, we have gas uptake into the lining fluid and then diffusion through the cellular barrier, so to say, into the systemic circulation. We recently built a generic in vivo PBPK model for inhalation exposure, and here we, so to say, address these different processes. And for example, I found very interesting this wash-in, wash-out effect. So when you inhale, so to say, you can then calculate how the concentration of the gas, so to say, is going into the lining fluid. And when you exhale, so to say, it's going again out of your respiratory tract. And again, it's, so to say, also coming back from the fluid into the airway, and then it's exhaled. So wash-in, wash-out effect is some of these processes. What I like to show you today is something else. What I'd like to show you before is that we also use in vitro ATME parameters to parameterize the system for the compound-specific data. And here we use this type of permeability assay. So we have a barrier model, which is built by respiratory tract cells, either from the bronchi or from the alveoli, Carlos-3 or Helvey. And then you can measure the permeabilities of the compounds through this barrier. You can also measure particle dissolution, and in RISC-Hunter we are now going to address also metabolism. And this can be done with submerged setup in case that you assume that the compound is a lipid particle, a liquid particle, or a particle, or you can also have it via a liquid interface where you think then about gases and other particles. I'd like to show you one example, what we, so to say, did in the Cefic LRI project. And here we, so to say, modeled different types of particles. Here we see iron oxides, which is kind of particles that you can inhale if they are below a certain size. And usually you would assume that these particles are completely inert. So when they, so to say, reach the different regions of the respiratory tract and go into the lung lining fluid, which has a neutral pH value, then usually they are not dissolved. But now you can also think about what happens as soon as they are, so to say, taken up by macrophages. In macrophages, they find a completely different environment. They find a kind of acidic environment. And here you can see that these particles, although they are assumed to be completely inert, they dissolve in these macrophages. And this is, so to say, one of our findings. So these macrophages, so to say, then enables dissolution of these bioinert materials and can act as a kind of reservoir, so slowly also resolving something that we would have assumed to be inert. And the other way around, for compounds like amorphous silica, you would assume quite the opposite. You inhale it and it's constantly or rapidly dissolved in the lung lining fluid, but is also taken up by macrophages at the same point in time. And in macrophages, it's not solubilized. And so like this, it is, so to say, delayed and could, so to say, also be delayed released to the respiratory tract and then into the systemic circulation. These are all the things that we can now model with in vitro or NAM data, put into the equation, and then improve our respiratory or lung model. I also want to give you a kind of outlook, because PBPK modeling is at the moment already working, but we have some more open questions. And here I like to give you an outlook of what we are going to do in Risk Hunter and also what we are going to do in Park, because Park is led by Philip and BFR is directly involved. And Risk Hunter is one of those ASPIS projects that we heard about, one of the recently funded biggest project in this area, and Bob is the coordinator. So in Risk Hunter, we have a special focus on metabolism, and metabolism is at the moment not very often factored in PBPK modeling. At least we could say hepatic clearance is factored in, so the clearance of the parent compound by the liver, so to say, is usually implemented, but the quantification and building of metabolites in the liver or in the barrier organs, that is at the moment not implemented very often, and this is one of our questions in Risk Hunter. So we will have, we are going to measure and develop barrier models for all kinds of routes of entrance, so like lung, skin, and gastrointestinal tract, and we are also developing models in vitro that allow us to quantify the metabolite which is built, and then we can assess, so to say, its systemic uptake and circulation, also in liver and kidney. I like to show you one of these models. It's developed at Uppsala University in the group of Per Artuson, and he is busy with the development of a model for the gastrointestinal tract. Here we have different questions like the passive transcellular transport, but also active carrier-mediated uptake and also active carrier protein-mediated efflux. So we have these transport questions, but also the metabolism question. We use the CACO2 cell, which is a quite often established and very robust in vitro system for this passive uptake and also to some extent to some active uptake. And at the moment, Per and the stream is busy with the development of a 3D organoid system, which can then be used to also quantify metabolism in the gastrointestinal tract. Then another thing that is probably of interest is Risk Hunter not only, so to say, focus on the barrier organs and the things that happen in the organism, but we are also, to some extent, interested in aggregated exposure. So how can we, so to say, link the external exposure part to our internal exposure, so the exposure models and scenarios to the PBPK world. And here I like to show you one example where we, so to say, want to aggregate dermal and oral exposure. Dermal and inhalation exposure. And we use this here for one compound which is very data-rich, NMP, to build up the model and then to apply it, so to say, and design the concept. And what you can see here at the moment, it's at the stage where we have reproduced, so to say, a study from literature, and it works fairly well. And now we will go to apply it to measure aggregated, to model even aggregated exposure. In Park, PBPK model is also one of the areas of interest, and here we have recently started, and we are now at the moment developing case studies to address conceptual data gaps in PBPK modeling, also to improve models that are already existing for relevant routes of exposure, and with the aim in the end to implement these models into regulatory risk assessment. And here you see 4 different examples on which we are working or will work in the near future. One case study is about the integration of the human microbiome and how it, so to say, contribute to the metabolism of compounds and how compounds then can integrate it in this modeling. Then also the impact of different isoforms, for example, from cytochrome P450 enzymes is one of our questions. We have one model which is dedicated to neurotoxicity, and here we want to better integrate active transport, or at least we want to better integrate the blood-brain barrier. And also the last one is interested in developing a tiered testing strategy for inhalation exposure, because we at the moment do not know very well which type of model we have to use to measure in vitro the absorption and metabolism after inhalation exposure. We have many options because we have different cell types in the upper and lower respiratory tract, and we want to better learn how simply this model can be and how complex it would be needed. Yeah, so kinetic modeling in next generation risk assessment, is this needed? I hope I could have convinced you that this is actually one of the key players in next generation risk assessment, so it's definitely needed, and I hope you have, so to say, gained more interest into it and probably would like to use this also in your daily risk assessment in the near future. Thank you for your attention.